online. I think people online have got their cameras off, which is good. That's what we prefer, because it works better. You've got me today, which I only knew last night. This is going to be at home. So I'll be chairing the meeting today. I'm just looking around. So I imagine most people know most people in general know everybody. But I just wonder whether we do a really quick run round. Starting with you.
Hello, I'm John Blake, I'm the Deputy Chief Executive.
Hi, Precious, one of the associate mayors.
I'm going to go to the back row.
Andy Forbes, new governor.
I'm Elaine Gilbert, I'm the new Division Chief of Work. Remark is being the Chief Nurse.
Hello, Ian, I'm the Chief Medical Officer.
Hi, Ganesh, I'm Associate there.
Good morning, Emma, the Chief Operating Officer.
Data same, nodding same.
Hi, Daphne Thomas, I'm Interim CFO.
Gary, NED.
Beth Messenger, my last meeting, and they've already got rid of my name badge. But I'm not going to make use of it. Just accept it. Danielle Patch, Chief People Officer.
I'm Craig York, I'm the Chief Information Officer.
Hi, I'm Dave, I'm the one of the notes.
And Kate Drummond, I am Chief Corporate Services Officer.
Jake, and we'll go to the back row.
I'm Julie Goodman, Head of Patient and Family Experience.
Hi, Lisa, Patient Experience.
I'm Amanda, I'm the Committee Secretary.
And I'm Timmy Atcham, I'm the Assistant Trust Secretary.
And we've got people online. So Timmy, you can see, we've got Tom, who's a governor. Piran, Magdalena. I don't know if anyone there wants to speak. Tom, that you're a governor. Piran, I don't know yourself.
Yeah, I'm a staff governor.
No. Christine.
Yeah, Christine Thompson, Public Governor.
Thank you. You're welcome. Nice to see you last night. Keith. Keith's probably going to show you a cup of tea. We've got Kenneth and we've got Madeline. Right, lovely. Okay, thank you very much, everyone. We've got quite a full agenda due to run until I think about 12 o'clock. So we'll start if everyone's happy, and we'll take apologies.
There was only one apology from Jason and, sorry, Mark.
And Alison. Are there any declarations of interest, any interest to declare? And we've all got lots today. That's good.
I'm just going to make sure that you are going to declare your interest.
Oh, I'm going to.
Excellent.
Yes.
That's also what I was going to do.
I saw Alison's message at 9 o'clock. Oh, hang on a moment. That's it. Yes, yes, I will.
You're always worried about
That was very about me.
I'm a member of the BSI Healthcare Organisation Management Committee, and I've just assumed chair of that committee. British standards.
Oh,
So I'm just going to note there, aren't I, that I'm on the agenda. And I'm obviously not going to present that bit about myself. You're going to, therefore, that's good thinking as well. I wondered who might be going to do that.
So just in terms of that, you're going to remove yourself from the item as well, or what's your plan?
No, it's already approved by the governors. No need to.
So it's a noting not approved.
Yes, it does say the noting, doesn't it?
But that's right, it's also not the approved one.
But thank you.
One of those.
I'm going to pause slightly more before between items, I think I really. Register of interest, which was attached. We don't need to do anything.
No, just those who verbally declared today. Obviously, that's really helpful from a transparency perspective. I'll update if everyone can just update their interests as needed, and if you send yours through to me or Timmy, we can update yours for you.
Thanks.
And everyone was happy with their part of that if they had a look at it, that it went through as they thought it was meant to be. Lovely. Okay, excellent. Right, marvellous. We can move on to much more interesting things. and patient story.
That is on there.
Yes, I didn't know if you were introduced.
We just confusion by you.
Lovely. Yeah.
So good morning, everybody. Thank you so much for asking us to attend today. We like to have the opportunity to talk about the work that we're doing. So obviously, for those of you, I'm sure you know, the patient experience team, we collect an awful lot of feedback by way of the FFT feedback that we have, complaints and panels feedback. And just to mention the FFT actually, is that we get around about 15,000 pieces of feedback every quarter, and that pretext comments, which you'll know about through the PEP platform, and that gives us lots more feedback than we've ever had before. So that's where we look to for our feedback, and as a team, what we want to do is obviously improve the experience for our patients, and using that the feedback. What we find is, as a team, that sometimes the patient experience is seen as a sort of pink and fluffy part of care in the hospital, and we want to make sure that it's obviously as important as the safety and quality of care that we give as well. And so on my presentation there, my heading, the small things can make a big difference, and that's what we've really found with our patients, with the initiatives we put in place, that those small things we do make so much difference to the patients on our wards and in our outpatient areas. So thank you. So I wanted to talk about Buddy. So who's Buddy? So Buddy is our patient experience trolley. So as I say, this came about as a result of feedback, and what we were seeing were that our patients were perhaps coming through an emergency route into hospital, or those patients that didn't have many visitors were perhaps in hospital without the things that they necessarily needed, and the things that made a difference to their life. So what we wanted to do was have it didn't have to be a trolley, but we decided it would be a trolley of items and information that we could take around the ward areas, especially the urgent wards, emergency wards, I should say. And we wanted to make sure there was information on there for people and some bits and pieces that would make a difference to the people's, patients' actual experience. So we came up with this idea of having the trolley, and that we would get some volunteers into the patient experience team and go out with this trolley. But what we wanted to know, obviously, was what our patients wanted. So there's no point us presuming we know what they want. So we did some extensive work, sort of the back end of the year before last, with our patients and from our feedback, to find out is, when you're in the emergency or urgent care pathway, what are the sort of things that you want when you're a patient? So we really did our homework and got some ideas. And we also had a competition that we held down in the main reception to actually, and as we was going around as well, to name the trolley, because we didn't just want to call it the patient experience trolley. So that went out to staff, and we chose a former chief nurse chose the name Buddy, because we thought that was quite apt with being Buddy as a friend, and it's quite funny. At one point we were going to have a Buddy Holly face on it, but we thought that might be going a bit far. But he is commonly known as Buddy. So with all the information we gathered from feedback and from the patients we spoke to, we have this trolley. So the trolley is full of information on the hospital, information on other organisations, friends and family forms. We've got combs, brushes, birthday cards. If someone's in hospital and they want to send their birthday cards to their loved ones, birthday cards, activities, magazines, books, and a whole array of items that somebody might need or want when they're in hospital. Because we all know that hospitals are quite boring as well. So people, when we go around with a trolley, people quite often want an activity to do. So with the help of the charity, we made the trolley up, and it's quite a huge trolley. And then we took on board some volunteers that go out. So Buddy goes out 3 times a week around the wards. We concentrate a lot on the emergency wards, but we do go into other wards as well, because we must remember that some people don't get visitors and don't get anyone coming to bring all their niceties in for them. So we've got some lovely volunteers that we've taken on, and they go out. And they're not going out just giving the things out in the trolley. What they do is they speak to the patients, and the patients are really happy to see the volunteers because perhaps they haven't spoken to anybody. And we get some really good feedback as well from the patients. So we do that part, getting the feedback, and then we just say to them, is there anything that would make your experience in the hospital better? And if we can possibly help them by what we've got on the trolley, we'll give them something. Another thing we have is radios, which we found is really good because people get really quite bored whilst they're here. So we've got, as I say, all sorts of things: toothbrushes, magazines, radios, earphones, and all funded by our colleagues in the charity as well, and some charity work that we've done as well. So we're really thrilled with Buddy, and if you see the volunteers around, please stop and speak to them. We showcase the trolley in the Milton Keynes Community Hub, which is the screen that's up now, which will tell you all about it as well, about how we come about getting it together. So what are our plans for the future? So we want to make this bigger and better and make sure that everybody in our hospital, gets a chance at some point to see our volunteers, talk to them, and get provided anything they might need. So we're constantly trying to recruit more volunteers. So just to say, the 2 volunteers go out together. We don't send somebody on their own. And when they first go out, a member of the patient experience team goes out with them for quite a few weeks until they're comfortable talking to patients and obtaining feedback. And, so we're not just dishing things out, so to speak. There is a good conversation before we do that. So the first ward visit took place on the 18th of January. So on the 18th of January, we'll be celebrating Buddy's first birthday. So we haven't decided what we're going to do yet, but I'm sure we'll celebrate somehow. So at the moment, with us to say, they go out 3 times a week with the volunteers, visit short stay areas and then other wards whenever possible. Because on the trolley there's also information and, as I say, the friends and family forms, we're getting an increase of friends and family feedback as a result of it as well, because that forms part of the conversation the volunteer has. And so we've obviously got some feedback to see how successful this has been, and we've had, I won't read it all out, but there's some feedback up on the screen from staff and patients and the volunteers, and they're the most important people in this process. So the staff, you'll see there's one there that a staff member wrote, "Your visit towards them made a few hearts happy and joyful. All the little thoughtful things you do, make a difference." And our patients are saying the staff were really friendly, the ladies with the trolley were lovely. And one of the patients said, "I've got my energy back. I felt so depressed. Now I'm able to do what I would do at home, wash, clean my teeth and feel human again." I just, it's a really lovely, heartfelt comment, isn't it? Really lovely. And our volunteers get so much out of it. They're a lovely bunch of ladies. And it helps them and puts a smile on their face for them to come in and feel that they're making a difference to those people on their ward. So that's all I've got to say about Buddy. And Lisa's going to talk to you about our clothing project.
Yeah, so our clothing project. So the question really was, how dignified would you feel walking around or going home in a hospital gown? And we have a really good working relationship with Age UK, meet very regularly, and they had raised some real concerns about taking patients home without shoes, without suitable clothes, without a coat. It was raised at the patient experience board. There's also complaints that we'd received to kind of to cover that as well. So the aim is to ensure that we have an adequate supply of clothing and footwear for patients who don't have their own. So that's for while they're in hospital, so to try and prevent deconditioning, to make sure they're comfortable to get up and get around about the hospital, and also to prepare them for discharge. So to make sure that patients are leaving with everything that they could possibly need. So as I say, a lot of this came from complaints. So they're up on the screen, quite a lot of quotes from complaints up there, which are not very nice to read. I'll let you read them, but a couple of things that I will mention. So there was a gentleman who said, in what seemed like seconds, all of my belongings were moved from my locker and side table. Bed was completely stripped. The fact that I had no clothes on seemed to be of no interest. I did find a pair of shorts hospital gowns on front and rear, and I was whisked off to the discharge lounge. Another lady told us that her mum was brought home from hospital, freezing cold condition. She'd had pneumonia, wearing a hospital night dress, open at the back, obviously no dignity for her, cardigan on top and bare legs. So that's just the couple. So we knew that there was an issue with this as well. We knew that, you know, we do a lot of work with the frailty team on this, and they had quite a good supply of clothes, but obviously couldn't get round and make sure that every patient had what they needed. So this project, as I say, has been very much a collaborative project with ourselves, the charity again, very supportive, the frailty team, Age UK and voluntary services. So through the charity, we have made contact with a gentleman who works in a warehouse in Milton Keynes. He gives us a really good supply of brand new clothing, a lot of which is good for patients, some of which is not so good for patients, so we can sell that stuff and raise some more money to get track suits, suitable shoes, whatever it is that we need. As I say, with voluntary services as well, they have helped us to purchase a couple of linen trolleys so that we have got a supply that staff can access whenever they need. We've got boxes going out to wards with a basic supply for each ward as well. Volunteers again play a really big part in this. We are recruiting volunteers to help manage this on a day-to-day basis. And the patients that we have spoke to and the staff have been really, really positive and very grateful. We've also supported the frailty team at some of their education events, so the hashtag NPJ paralysis as well, getting patients up and getting them moving. And so I put on the bottom of this slide, the thing that we're kind of struggling with at the moment is the storage of the linen trolleys. As I say, they're two quite big linen trolleys. We need staff to be able to have access to these 24 hours, 7 days a week. So anyone has any ideas of where we might be able to put these, that would be really helpful. At the moment, we've got one down in the linen room. It kind of tends to get quite hidden towards the back, which I understand that's a really busy area. So that's kind of the shout out for that. So the project in action, we are carrying on. There's some photos there of one of the sales that we held. Our support with the frailty team with one of their events as well. And then just a couple of very brief patient stories. So I'll just read one out, but there was a very vulnerable young lady on ward 20. She'd arrived from supported living late at night in her pajamas, nothing with her, no one who could bring anything into her. She was ready to go home the next day and had to get the bus home. So she was given outfit, new shoes, everything that she needs so that she could be discharged in a dignified manner. And she was very, very pleased, and the staff were very grateful. So yeah, there's another couple up there that you can have a read, but yeah, it's made a real difference to patients. So yeah, is there anyone got any questions?
Thank you, thanks.
Any questions?
Thank you very much. So really good to see some of the impressive and impactful project work, particularly around clothing, but also body. I guess I'm just looking at page 13, which is the quotes from complainants, and 6 quotes there, and I'm sitting here feeling the most uncomfortable I've ever felt at a board meeting in Philippines. And I guess whilst it's great to see the project work responding to some of this, I guess it's how I have those discussions with our teams on the wards, with my medics, etc. And I'm sitting here asking myself that question before I do slightly. So it's how we have this discussion widely across the organisation. Does that make sense?
Yeah, certainly in the patient and family experience board, especially the clothing project, has had quite a lot of discussion, hasn't it, Yvonne, about how we can spread this the nursing staff.
Just to add, that board looks at this in quite some forensic detail, and this particular project was on the back of some of that feedback, which I'm sure it doesn't happen in the future.
But you just be clear that this isn't a project, this is core standards.
Of course, yeah.
I think it's a good point, because I think that's the question I would have asked, kind of what is the core standard in terms of patients' dignity, discharge, clothing.
And it's not what's on page 13.
Yes. Yeah. So I think that's I mean, clearly excellent work and making such a difference to how people are going to be feeling, isn't it? So that's really what we want to see in terms of that, how to change. So well done to the team for doing that. I didn't think Buddy ought to have a face funny like that.
I'm still, yeah, I'm still tempted.
No, not Buddy Holly's face, but her face. But, sort of, okay, so Any other questions?
Just to pick up on Ian's point, I think we often get very hard hitting complaints. We don't, and I thought it was important not to sanitise the wording of these. You know, and not to make them sound like they were, you know, because actually this was how that person felt. And you know, there might be context around that experience and you know, and all sorts of other things that we might say, and you know, but I think it's important sometimes that we hear that direct voice from the patient about how they felt in that moment and how we've then responded. And so you're absolutely right, Ian, and it is very uncomfortable to read, but it's, I think, important nevertheless that we read it in the way that they have relayed that experience.
So I was just wondering really, I know that a while ago we had conversations about things like dressing gowns because everyone recognises the dreadful hospital gown which goes up at the back. But what I don't really understand is why this has to be a charitable thing. Why don't we provide simple tracksuits for privacy, dignity, and all people going home just sort of off the shelf in wards? You know, it would cost very little, just you know, judging by what you can buy these for. Why aren't we doing this anyway?
I think my understanding from discussions with the frailty team who have been very involved is a supply issue. It's they're trying to find a supplier who would supply them.
So I think that is sort of a dreadful. I cannot believe these things are difficult to buy if you go to sports stores. Any number of these items. I just think, you know, that it wouldn't cost a lot of money. It would be significantly forward, and you know, the vast majority of our patients won't need them anyway because they will have relatives who bring in suitable clothing or they come with suitable clothing. But I can't see why this isn't our responsibility if we don't do it.
So just to come on to extend what you're saying, John. So part of the patient experience board was to implement this really quickly, which we did, to respond to the themes that we were seeing emerging through this. The next part of this work is we want to get our patients up, dressed and moving as a normal part of everyday, what you'd say core practice. And that will be that extended looking at can we provide this in a different way. And it's a bit like what Lisa said, we're having difficulty on where do we store the clothing, and part of the work of the patient experience board is to try and resolve those problems. So it's an evolving process.
So that
an end in
John's
itself.
is effectively sat already inside.
Yes, it's rooted inside this board trying to look at.
And therefore the trolley storage is something we'll take away post the meeting and we'll work out who's going to work that out.
Thank you.
But very interesting. Thank you very much for coming.
Oh, I'm so sorry. No, I was just going to say that so if on through space committee, we can find a space for it.
Thank you.
I wasn't sure what the committee would be. I thought there must be someone there who does space. Thank you very much for your time. Thank you.
Take care.
So, moving on, minutes of the last meeting. Has anyone got any corrections of the minutes of the last meeting? Or any comments? Yeah.
Not corrections, but I just have a procedural question, I suppose, more than any comment. I think these are minutes from November. So I'm wondering if it is possible to get the minutes sent 3, 5, 10 working days after the meeting rather than looking at it 2 months down the line, because that we'd have a bit of memory of what happened at that time rather than 2 months down the line. The other question I had around the minutes was, and that just might be me, but it feels like this is just a summary of the agenda papers as opposed to the minutes of the discussion that was had, because it feels like it's all about the summary of the presentations rather than the actual discussion that was had during the meeting. And I wonder whether others feel the same or no.
I think the question is, what do you want the minutes to reflect? I think that's a good question. You can have your minutes reflecting the actions, so you don't have a long set of as opposed to a verbatim sort of 3 people said this, 4 people said that.
No, but I suppose should it actually reflect that there was a bit of discussion that's happened around.
And that's the question. You could say we're going to document the discussion.
Yeah.
Or you could say, all we're going to document is the action that came out of it. And I think that's the thing we're talking about. We do have the verbal recording though, don't we?
Yeah. Yeah, I think my view would be we probably should have something closer to, we should move a little bit closer to a verbatim minute on discussion items for, and so I can pick that up with the team and just, and so we moved, I think we've perhaps drifted more towards a more action-based set of minutes and perhaps need to just rebalance a little bit towards more of a capturing more of the discussion. We do have the recordings as well, but nevertheless, and we can absolutely do that for the representative itself.
Yeah,
So,
I'm assuming that you because I think Gary's point, both points.
Yeah.
Valid, that kind of not he said, she said, one said this.
Yes,
said,
definitely.
like the discussion talked about.
Yeah.
Yeah.
And the agreement was.
Yeah.
Yeah, I think that makes. I think you're right, and I think as well sometimes over time minutes do move and drift into effect and then can come back to somewhere, can't they?
Yeah.
So I think it's a really good point.
Thank you.
Timing of distribution, sorry, I knew there was a first point you raised and my mind went like timing of distribution. Kate, is there anything in that that's going to be?
So we can send them around for drafting errors, and then they'd need to come back just for here, or just here as normal. But yeah, we can do that. The draft very quickly off the board. So
there's no reason not to do that from a process point of view. Any other comments on the minutes? No. Thank you. Matters arising. Just two.
Both closed.
They've closed, aren't they? Nobody's got any comments on that. I'm going to then hand to Joe, I think.
Do you want to hand seamlessly to
Kate? Sorry. I've got to keep thinking to myself that it's going to you if it's not.
So this paper is a paper on extending Heidi's tenure as a non-executive director. The reason that Heidi doesn't need to be recused from this discussion is because we are not, as the public board, the approval body for this appointment. The approval body is the Council of Governors. So they have already approved the extension of Heidi's term of office. And so this paper is here for noting. So just some explanatory, some more explanatory narrative in this paper, because usually a non-exec director would do 2 terms of office, a maximum of 6 years. The NHS Foundation Trust Code of Governance allows that to be extended for a further term, so up to 9 years. But they ask that, or they recommend that that's subject to a rigorous review. That's the point of 6 years, to make sure that the appointment, extending that appointment, is the right thing to do from a governance perspective. And that's about retaining objectivity on the board and being able to get the balance of experience and objectivity. The board, for a variety of different reasons, we felt that are detailed here. It was recommended to the governors that we extended Heidi's term for a further period of 3 years. So that is the recommendation. The governors accepted that recommendation. So this paper is here.
So 2 questions, because I'm being a pedant today. I appreciate you sent to note. The cover sheet didn't say that for approval, but if we have in the minutes, it is to note. And secondly, recognising we're noting it, so unfortunately, feedback to the Council of Governors. Just when reading through the paper, in terms of and this is not about Heidi per se, but about the national guidance, a further 3-year term fine. It is then possible for further extensions with NHS England approval, and arguably we've tied ourselves in not a bit at the end by saying it wouldn't be beyond 9 years full stop and set our own criteria.
So the extension actually is if and that non-executive becomes chair. So then it does a slight reset of what is permissible within the council, within the code of governance. So extending beyond 9 years is something that unless you are then going on to being chair or in a slightly different role.
Right, so it's just for me the word final struck me as probably unnecessary and to tie ourselves up slightly.
I don't agree, but that's fine.
You would have thought 9 years was enough for it.
Indeed.
Okay, it's noted.
Thank you. It's very nice to be into. Thank you very much. Chair's report. I haven't got any handover notes from Alison because it was only quite late last night that I knew she wasn't going to be coming. So I thought I just would mention that we did do some company secretary interviews, but we didn't appoint. So we are going round again. And I think I had some conversations actually with governors last night about the company secretary role, which I might have a discussion with you later if possible. I think people are seeing the importance of that role, and especially in the busy times that we're living through. And then just to say that we did meet with the governors last night for a meal and had some really good conversations about kind of developing working practice, finding perhaps more formalised ways of operating together and spending more time together. And it was actually really nice to spend time with people. So that's something that I think following that we're going to pick up with different members of government. We've got different ideas that came out of that about how we could help structure it, how we could help bring ourselves together as the two entities and continue to develop it. I think off the back of the fact that we obviously now have a full cohort of governments. Anybody else want to mention?
Oh, the only couple of things. One is on the back of the governors. I think they did feel unsupported kind of by the organisation to fulfil their duties and unable to do them because of lack of skill and knowledge on their own part. So those two factors played in, and that was quite interesting. And I made a mental note to try and understand what is available to them, and that has to be set in the context of Kwame leaving, because that's also part of someone they look to help support them. And so it's particularly that they feel somewhat adrift of all of that.
And I think there was a difference between those trustees and governors who have done longer, and that was acknowledged actually on the group I was talking to, who have done longer, and those trustees particularly as well coming in new, who perhaps felt a little bit like, I don't quite know how to take what. So I think it was a good conversation. It was a very positive conversation. I think across quite a big group.
I think it used to be that we ran regular, this was pre-pandemic actually, because obviously it stopped then, it hasn't really restarted, but we ran regular whole day training sessions with governors that were run by either the providers or compared, I can't remember which one. And I think we need to restart something of that nature. Obviously, Kwame, it's always, Transport Secretary role is almost never noticed until it's not there.
Yeah.
And everyone's like, well, it is a huge amount. So we did, as I described, try to appoint, weren't able to appoint. Looking to get in some interim cover. Obviously, Timmy and Amanda doing an amazing job in supporting as well. And then with the adverts closed yesterday, so I've just got another set of shortlist.
Just diving into just what you said, but one of the things I heard last night was around not generic training about governance responsibilities, but I do think that's very important, etc. But quite specific training around this is the performance report, yes. These are what these three-letter acronyms mean, this is how we use this data, this is the finance report, this is what's key about it, because quite a lot of what you get, in fact, the more you summarise it, the harder it is often for someone who isn't quite knowledgeable about something to understand what the key issues are. So I think some sessions from key, for example, Daphne or John on some of those key issues, or Danielle would be very welcome. This is my report, this is what it is, this is what the data is, this is what, that would go a long way.
We came up with some good things, good conversation.
Oh, it's a good
session. Follow through, and I'm going to make sure that some of us make touch points with, so that we can kind of structure that and have that developing over the next 12-24 months. Particularly with the now full of cohort, but obviously been partly as part of helping to achieve. That's all I've got, I think.
Thank you, Chair. A couple of things to update the board on, if I may. Firstly, from the agenda, the update on the Commission's pieces of work. I have, following the last board meeting, spoken to Yvonne Coghill, who is going to provide us with her proposal by the middle of January. to come in and do some work with groups of staff around their lived experiences. And if you recall from the conversations, that was separate from the Roger Klein piece of work, who is equally, we're waiting on to send us a proposal, who is going to do some specific work with HR around some of the res data. So if you recall the conversations we had, Roger was much more focused on the numerical statistical side of the work and the data side, and Yvonne, his expertise stretches much more into the lived experience and discussions with staff groups about ensuring lived experiences matches what we would hope for. So that's progressing well, and the third piece of work, we've had the conversation and we have a series of bits of work that have come through that we need to complete for the NHS England board governance review. And the first part of that will be a desktop exercise, and then it will be board observations. The second piece of work, obviously, we'll talk about a bit later on the board. So that's that. I'll take any questions at the end if that's okay. The second bit on the agenda is in relation to staff access to NHS services. And this follows various executive conversations. I want to bring it to the board to get a view from board members. And that is around, we know at the moment, the team here at MKUH is a microcosm of our population. And as a consequence, we have a relatively small number of individual members of staff who are unable to work because they are awaiting some form of health intervention. Okay. Good example, we might have an acute physician who is unable to carry out all of their duties because they're waiting for a knee replacement. We believe that there is a case that we should be, for non-emergency care, be ensuring that those individuals are treated as a priority in order that they can come back to work and treat our patients. So the example I've used, if our acute physician is at home and unable to work because they're waiting a knee replacement, they are unable to look after patients in our hospital. And that hits the organisation in a couple of ways. Clearly, we would be paying almost certainly a significant premium for an agency member of a doctor to come in who wouldn't have necessarily the experience in the same way that our substantive member of staff would be, and we would obviously be paying for that individual to be at home. So what we would like to do is bring a paper to the board that prioritises members of the MKUH team in order that we can get them back to work to look after the patients that we have to look after. But I didn't want to bring a paper back until I had surfaced that with the board to see what the views were around the table. I'm talking about planned elective care. I'm not talking about if you walk into ED, you'll get special treatment.
Can I remind myself, did we talk about this before?
Very briefly.
Some time last year?
Yes.
Yes. Okay. And questions? Thoughts?
Not a question. I'd be very supportive of this. I think we did talk about it before, and I think there was.
It might have been part two. That's why.
Oh, I see. Sorry. Yeah.
That's fine. It's fine. I remember the same memories.
No, I think it makes a lot of sense.
I continue to be supportive. Makes sense.
I just think we just need the rationale in the case set out clearly. So if we need to articulate why Group A are getting support and Group B are not, we can state it clearly.
And if I may come back on that, because if you like, I deliberately chose a clinician to use as an example. My view, and again, I'll test it here, is that actually the person in HR who is responsible for pressing the button to ensure that everybody's overtime gets paid, or if it's somebody in information that is responsible for sending the hospital HES data up to the region, they are as important a member of the team as the clinician doing the ward round who isn't able to work, as is the person in the restaurant who's serving the food to staff at lunchtime. So when I talk about team MKUH, I'm talking about team MKUH, not just clinical members.
Sorry. I like the idea. I think as per our previous discussion, yes, we are supportive of that. But I think the concern I have in terms of the public perception is, and unless it is presented as a staff benefit, which it may be, I don't know. But I guess the concern is that people who are waiting for knee replacement outside, so they're not within the part of team MKUH, they need to go back to work as well. So why, and obviously that has an impact in terms of their work or whatever work that they're doing, and it has a knock-on effect on the society in general in terms of their input. So why is that different to what our team here is doing, and how does that impact on it? I think that's and is there a concern around Equality Act or something, I don't know what the implications of that, is that something that we need to be thinking about?
If I may, then two things. One is that we know that nationally there is a piece of work going on about whether there should be differential priorities of patients on waiting lists, other than just the current arrangement of clinical urgency and length of time waited. So we know there's a piece of work going on there. Interestingly, when you said staff benefit, I almost had it in my head as a patient benefit, because if we can't get these people back to work, the likelihood is that our waiting list will grow. But I take the point in time, we need to think about how we phrase that when we bring the paper back to the board.
And also kind of any tax implications for the individuals involved.
Thank you. Supported in principle, I think that there needs to be some clear safeguards. So, for example, we know that for a million reasons, we're not quite as efficient as we should be, and patients, for example, don't turn up at short notice, and therefore, I think where possible, we should try and squeeze patients into resources that might otherwise have gone to waste. And secondly, I think we should be clear that that you won't go ahead of patients who are clearly in need of greater need. So, for example, if you're a routine patient, you wouldn't displace anybody who was on a cancer pathway or something like that. You might go to the top of a routine queue if you were routine, and send sort of safeguards like that so that it's not seen as disproportionate.
Totally agree that we cannot have we cannot undermine the clinical urgency of individuals on the waiting list. That's really important.
Yeah, I completely agree with what John just said, and I assume the paper would set out those points that we brought to the board. My question is there precedent for this? Has anyone else done this?
Not that we've been able to find. We know that there are informal arrangements in some organisations where people are moved through, but we haven't been able to find any written documentation on it.
My question is just going to build a bit more on the benefit in kind thing. Would this end up being a staff right or a management discretion?
I think that's a really helpful question to answer in the paper.
If it's an entitlement, like recruitment from
So I just think floodgates and all that, but if someone from primary care said, look, the GP's gone off sick, if we can get him back to work, you can see another 100 patients a day, where this stops and how we manage those sorts of challenges, if this has become effectively policy.
100% agree, and I'll give the same answer as I do with the way that we manage other staff benefits, which is entirely appropriate for other organisations to follow in the wake of what MKUH does in terms of leading the staff benefits.
So the only thing as well then, if I think it is, all these points need to be addressed, don't they? So that we don't step on that or something difficult. But in terms of staff benefit, if it's equating to health benefit and taxable benefit, we've got to be careful as well. I think we've just got to make sure that we understand the piece list. I think the paper needs to address all of that.
Sorry, not a comment. There's a comment on the Teams page that the audio visual experience isn't very good today. Obviously, it's not much more.
Being very quiet. We need to
Maybe
speak up.
not, is it because we're not speaking? Yes, we'll try to make sure we're speaking more clearly.
And when providing feedback, it would be really helpful, you said in a very loud and clear voice, to be clear about which speakers can't be heard. But that is a serious point.
Exonerating yourself.
But no, we know, and the exec team know that there is that differential. So please don't be bothered about naming individuals.
Just shout, and I'll speak up more.
Okay, so that's helpful. So the plan will be as an action to bring a board paper back in to the next public board for further debate. Thank you. A couple of other things from me, if I may. There is a paper in the board pack from the ICB, and that is around setting out some of the things that have been going on. And again, happy to take questions or any sort of comments on that. Next one is.
Sorry, can I?
Yes.
Oh, right. Just on that paper, in terms of the system response to Denny review, obviously it's stated that all partners have agreed to consider how the recommendations would be implemented and such. So what is the implication for MKUH in terms of what needs to be done, and is there a process in place for that?
Yes, there is. So if you will recall, the Denny review was circulated as part of the last set of board papers, and we have got some work coming back to the ICB from a place perspective to understand what the places are doing. We've got a session, I think later on this afternoon, in with the council and community mental health providers about how we can ensure that we are doing what's required to support the Denny review. I think it's fair to say that the work that we have been doing here around equality and equity of access is helpful in supporting the delivery of some of the recommendations of the Denny review. We also know that there are a number of areas, waiting list being a good example of where we have looked in the past but not been able yet to put in a process to understand some of the implications of the diversity of our waiting list, and we have further work to do on that. Can I suggest that we bring something back in sort of 3 months' time to answer the specifics of the outputs of the Denny review and what the place is focused on, and then what MKUH is focused on within that?
Yeah, no, I thought that there's obviously work going on in terms of those reviews and things, but how that tied in with the specific recommendations. So I think if we could have that paper, it'd be.
And I think, if I may, Danielle, the piece of work that you will be asking board members to do around signing up to specific objectives that we were talking about yesterday. Do you just want to say a little bit about that?
Yeah, so you may or may not be aware there's 6 high impact actions required of the organisation in relation to the National ED&I Equality, Diversity Inclusion at Work. One of those is that every board member has an objective, specific objective, measurable objective in relation to that. So we'll be bringing that back, I think, to the February seminar, so each board member can consider what they would like theirs to be, and then we'll get that documented.
Just to reinforce my reputation for pedantry, section 2.3 of the ICB's paper is asking us, I think, as the trust board, to authorise the CEO and the chair to agree to changes to the joint forward plan outside of formal board meetings. Given the joint forward plan is, as I understand it, a strategic direction document about where we're going to be in 2040, it doesn't feel like any of that's particularly urgent. I'm just cautious about what we're being asked to delegate as a matter of principle rather than any concerns about a specific issue.
You're on fire today, aren't you?
On that, I know from a system viewpoint, where I am, where we're just we're going through that review of the initially submitted joint forward plan. So I guess it's because it was a co-produced piece of work, and then we're adding our updates to it. So I'm guessing it's going out to the organisations and ensuring they're happy with that content and contributing that way. So that's how I see that. But, yeah. Is that what you?
I'm much more cynical than you are. Yeah, I think we're being asked. You could read this. We're being asked to formally delegate something. It's not quite clear what we're delegating and why, and I need to therefore say no until we understand what it's being asked to talk through.
So is there an element in there, Ian, of when the trust chair and the CEO are going to obviously be trusted or assumed not to agree anything that isn't?
Of course, simply in principle, an external organisation, i.e. not us as a board, has written a paper for our board on this day asking us to do something. We need to be really explicit about A, what the ask is, and B, whether we're going to do it or not. It could be Joe and I could take this back to our meeting this afternoon and we could discussion with partners and we can see if there are other views.
Since it's not possible to bring formal amendments to a trust board meeting due to time issues, wouldn't there be able to be a outside of process discussion?
So I suppose I would turn it around and have a minute in our board that says that this board is comfortable that the chair and chief exec we can delegate to the chair and chief exec unless there is a view that it has to come to board specifically. So my point being is that we routinely trust the chair of finance committee or whatever. We delegate outside for specific issues. I would not expect the chair or the chief exec to sign things off that had a detrimental impact to the organisation without having a conversation with the board. That to me is like irrespective of what this paper says. So I think as long as we are clear that the chair and chief exec won't sign something off that has a detrimental impact without having that conversation with the board, yeah, that's reasonable.
But given that it says significant amendments, which gives you quite an open, I'm joining the pleasant background now, is there not something in there just inserting in consultation? So you know what the significant improvement is before it's been agreed, which is what I think you're saying, but I'm just trying to formalise it a bit more.
But by definition, this is in relation to a 2040 forward strategic plan. It's not in relation to what happens to X million pounds next week. It just,
yeah. I just wanted to make sure I understood this. So this is at the ICB board, you would have the authority to amend the forward plan at that discussion. I wouldn't be usually surprised about that. It's kind of what I would have thought a chief executive would do.
It's not the ICB board. It's not the ICS board, because the chair has nothing to do with the ICS board.
So
it's our board.
Okay, so the sitting within the ICB paper is.
I think Ian has raised a really good point. Third attempt. And given the level of confusion, I think it is important that we seek clarification on this. How about that? So we're not saying we won't do it, we just want to seek clarification. And we won't delegate outside of this board to the assistants to do this. We'll do it properly and bring it back. Okay, excellent. Good.
Can I ask one more question on that, on the ICB paper? On the BAF, do you attend the ICB?
Mm-hmm. Yes.
Yeah. So,
absolutely.
The BAF does the BAF work through up from the system?
So it's one of the things that we're working on at the moment is making those links more explicit. So when we bring back the renewed board assurance framework in February, March, that's something that we're trying to establish, is that much clearer link around system risk and our board assurance framework.
I understand that there's a long picture as well, but some of them it feels like there's a sort of gap.
Yes,
Between us, I'm not sure about the.
We're in the process of identifying what risks, from our perspective, should be sitting on the back. And then I guess the other issue would be when one of our risks becomes that significant that it should sit on.
But
case to summarise it. Really.
And I think that's really helpful. Sorry, Jim.
That's good, no? And then we get on to matters slightly closer to home. For information to the board, we have the Health and Safety Inspectorate coming in on the 29th, 30th of this month. You may recall that we are one of 25 organisations nationally that have been selected for this, which is great. And we look forward to welcoming them over a 2-day period, 3-day period. And then finally, I will look to Ian to give a bit of an update on the strikes and how the organisation has been dealing with the strikes. So Ian, over to you.
So I think the organisation for January feels challenged and feels pretty similar to a normal January, a little bit worse around the edges, but pretty similar. In terms of the strikes, clearly strikes of junior doctors in December, and then the longest strike in NHS history, which concluded on Tuesday morning of junior doctors. Here in the organisation, staff have coped remarkably well with this. So other grades of doctors, and I think probably more importantly, nurses now and health professionals have really rallied round to keep the organisation flowing. Really importantly, I'm not aware at this point in time of any significant safety issues that have resulted from the industrial action, which is impressive. Clearly in the background there's the opportunity cost and the elective work that hasn't happened as a result of the industrial action, which is obviously a source of huge regret given how long the waits are already. But we've survived. Our patients, I think, in hospital had a reasonable experience despite the stress.
And of course, my health inspector. Do we know what they do when they come?
Respect.
So they've got a very detailed programme over 2 days. They're looking at 2 things specifically. One is violence and aggression, and the other is musculoskeletal disorders. So they've got 2 teams of 2 who will look at each of those issues, visiting different parts of the organisation, talking to quite a large number of staff around their experiences in those 2 different areas. And very much like the CPC, they've requested lots of information, before they come in to visit, and looking at lots of intelligence about those 2 different areas and how we deal with those.
What's your thoughts on it, Kate, given it's an area...
Let's speak up, Mary.
Sorry, what are your thoughts on it, Kate, given it's an area where we've seen increasing incidents over time, and it's been a difficult area to address, and it's been top of one of the concerns that we've discussed as a board?
Yes, so I think the health and safety executive are very, they've got very prescribed in law formula around how they inspect. They look at risk assessments and the policy framework and what better than anything else. What are you doing? Are you doing what you say you do? We know that it's an issue for us, and that's evident. Around as it is in most organisations, around the changing demographic of patient that we are dealing with and the challenges that poses. I think it'd be really important for us to demonstrate all the work we've done around mitigating risk. And we have done a huge amount of work. We can demonstrate an awful lot of work that we've done around mitigation of risk and support for staff. And we know that there'll be areas for us also to keep improving. That's absolutely will be the case. So I think it will be. We've never had an inspection like this from them before, so it will be a learning experience for all of us.
Yeah, no, I think you think it'll be quite process focused on whether we. Yeah, thank you.
Thank you, Joe.
Oh, sorry. I was just going to add to what Kate said, that you may remember that we did form a working group about 18 months ago on violence and aggression, and we did do a tremendous amount of work. So we're in. We have a lot of we can provide in relation to that, and also we do have a dedicated staff physio on site as well to help with the MSK issues. So always more work to do, but a lot of good work has gone on already.
SI report.
Thank you. Firstly, thank you to Tina from Kate's team, who has written a comprehensive report here. The things I'd like to highlight in the report starts on page 34 of the pack. Firstly, the serious incidents reported during December. That table does contain 2 incidents which on the face of it are concerning. I want to give a little bit more context about those. It's both a maternal death and separately a never event. So the maternal death is under investigation, but the high level information about that is this is a case of what's called SUDEP, rather unhelpfully, sudden unexpected death in epilepsy. So a patient with epilepsy who died at home, unfortunately was only found to be pregnant on post-mortem examination. So whilst it falls into the maternal death category, clearly it's a rather different investigation. Initially, no obvious significant errors of omission on the part of health services, but and then the final event in the table is a never event. This was a bone marrow biopsy which occurred in the incorrect patient. Two patients with the same first name sitting in a waiting room and called by the first name, and the incorrect patient goes and has a procedure. Now, clearly that rings all sorts of alarm bells in terms of positive patient identification. We're doing lots of work on that in that service and elsewhere. It is no or low harm in that the patient who had the bone marrow would have been having a bone marrow in the next 2 or 3 weeks in any case, and it has yielded valuable information, but clearly it's of concern. We took the decision to report this as a never event, even though the national guidance suggests some grayness there as to whether or not it meets the definition. In our view, but it's clearly very important. On the next page, we talked previously about radar incident reporting rates being lower since we replaced our old system with the new one, radar. You can see from the graph that that's picking up nicely. It seems to be sustained, which is great. We've also talked about some of the issues around overdue incidents, i.e. timeline from reporting to closure. Kate and I have done a lot of work with divisional and corporate teams to try and reduce that number. We almost halved it. It's gone up again over the festive period with strikes and everything else, and obviously there's an impact when colleagues are forced back to the front line because of strike action. I think importantly, Kate and I now have better insight into the nature of some of these delayed incidents, and therefore I think our sense of risk around them is less than it was previously. An area we carry on working on. On the next page, training, you'll be conscious that PSERF is gradually transitioning in. We'll formally launch PSERF on the 1st of April. I switch to it as our standard operating model for incident investigation. And there's lots of training going on provided in-house by our patient safety specialists with 200 members of staff who are involved in complaint responses and incident investigation who are currently being trained. That's going well. Final thing to say, the last item on page 6 of the final page, there's an inquest tomorrow which relates to gentamicin prescribing. And colleagues will recall that we discussed a case a couple of months ago about tycoplanin prescribing. We're going to inquest at that point to assure the board that there's lots of work going on to work out how we can further optimise our electronic prescribing systems in terms of introducing additional safety measures. That work was well received by the coroner a couple of months ago, and I think it's all progressing.
Thanks, Jim. Thanks, Ian. Just in terms of process with the first one, the operation on the or biopsy on the wrong person, do we scan wristbands before procedures?
So it varies a bit on the environment in terms of inpatient or outpatient. This was a patient sitting in a mixed outpatient environment, and it's a procedure done on an outpatient in a procedure room. In this case, no. There is a policy around positive patient identification. This patient was not positively identified clearly, so there is lots of learning that wouldn't involve wristband scanning if something hasn't been completed.
Okay, so we do it for the majority of procedures.
So for theatres, etc., yes, yeah. and for administration of medication.
Would the simple answer to this be extend that to everyone? Is that
may be part of the answer? As I say, this is only at the beginning of investigation, so we're looking to. Yeah, thank you.
So the avoidance of death in an outpatient setting wouldn't have a wristband on. You would turn it up from home to an outpatient setting. So the absolutely valid point. Obviously, we should have had a way of properly identifying the patient, but I don't think that this type of procedure, a wristband, is ever going to work. We're not going to put a wristband with every single outpatient that turns up. And just to say, it might turn to be a pen. The graph on page 36, really we've got to start using statistical precedent control charts. These sorts of random banana line is completely inappropriate for the processes that are going on here. So we ought to do a different type of chart. We should Trying to randomly fit.
I agree, John.
What have you both had for Christmas?
Word of the day toilet paper.
Can I just ask one question? The thematic review on the endoscopic procedural cases by the Associate Medical Director, where will that get reported to?
That's a very good question. It's been to our serious incident review group. It will also come to the quality and clinical risk committee.
Sorry, I might have asked this before. I just wondered about the learning pathway for these serious incidents and learning that comes out of it. Obviously, you've mentioned that it goes in the weekly CE newsletter, and of course, we look forward to doing that. But I wondered whether there's a more formal approach as well to demonstrate that learning and.
So there is, and I'm going to look at Kate's decision to defer to her and sits in the team, what I can do as well.
So there's lots of different ways that we do learning, everything from debriefs at the time